Thank you everyone for coming. We have a full house and we have many people online as well. Dr. Spence is a very valued speaker, so thank you all for coming. I'd like to welcome you all to today's University of Ottawa Heart Institute Grand Rounds. We're very honored to welcome Dr. Jessica Spence from McMaster University. For this hybrid event, we have an audience members in person and also audience joining online, and we will take questions from both in person and online after the presentation. For those joining virtually, please submit your questions using the Q&A feature. We will also accept live questions at the end and use the hand up feature. You'll be asked to unmute by the moderator, which is myself. You can use the chat feature if you're experiencing any technical difficulties. For those who've just come in, I think we are getting more chairs. You're welcome to stand around the back and we'll get more chairs coming shortly. Dr. Jessica Spence is a cardiac anesthesiologist and intensivist at Hamilton Health Sciences, a scientist at the Population Health Research Institute, and an assistant professor at McMaster University, who began her faculty position in 2021. She completed residency in anesthesiology, a fellowship in critical care medicine, and a PhD in clinical epidemiology at McMaster University. She completed her fellowship in cardiac anesthesiology and TEE training at the University of Toronto. She's an active clinician scientist and leads a research program that evaluates the effect of non-surgical intraoperative interventions on the postoperative outcomes of patients undergoing cardiac surgery. Please join me in welcoming Dr. Spence.
So thank you so much for the invitation. I really am very honored to be here invited today. So recognize it. So I'm going to talk today about a rabbit hole that I kind of went down. So I'm very interested within my research program in studying the things that we do in everyday routine clinical care that often don't really have much of an evidence base for them. And so I'm going to be talking today about perioperative benzodiazepines. Many of you, I realize this is sort of a multidisciplinary crowd. So this is not anesthesia specific. This is truly perioperative. These are patients before, during, and after surgery. So the data that we're going to be reviewing applies equally to patients having cardiac surgery, patients who are in the cath lab getting an angiogram before their potential cardiac surgery, and patients who are in the ICU or on the cardiology or cardiac surgery ward. So these are my disclosures. None of them except for the funding stuff is really relevant to this talk. The trial work that I'm referencing was funded by CHR, Heart and Stroke, HASO, and ACT. These are the objectives. So I'm going to start by talking a little bit about the evidence supporting the use of perioperative benzodiazepines in cardiac and non-cardiac surgery. And recognizing that these medications are germane to medicine. Like, we use them all over the place for all kinds of purposes. They're everywhere. You can just run through any patient's MAR and there's a decent chance that there will be a benzo, either as a home medication or as a PRN medication in hospital prescribed. We're also going to look at the evidence of harm resulting from perioperative benzodiazepines. And then finally, we're going to talk a little bit about a practical approach that kind of integrates these benefits and harms and to provide some recommendations about what's the best way to take care of our patients. So benzodiazepines during the perioperative period are often used for their presumed benefits. People are often worried, particularly in patients with critical cardiac disease, that anxiety and stress is actually going to make them ischemic before surgery. And so they're used to prevent and manage preoperative anxiety. There is some limited evidence that they help with postoperative nausea and vomiting, and they're thought to improve patients' overall quality of recovery. And this is relevant both in the cardiac surgery setting and in the non-cardiac and ambulatory surgery setting. Furthermore, their amnestic effects are often thought to prevent this phenomenon of intraoperative awareness, which is more common during cardiac surgery and something that everybody is very worried about, because even though it's very rare, when it does happen, it can be very traumatizing for patients. Recently, though, there have been a number of concerns raised about the potential adverse effects of perioperative benzodiazepines, and these include postoperative delirium and postoperative cognitive decline. So there's a number of perioperative guidelines that have been issued that recommend avoiding perioperative benzodiazepines. But it's really important to acknowledge that these guidelines are based on expert opinion. They were not informed by meta-analyses. They were not informed by evidence. They essentially just were a bunch of people sitting around in a room, sort of reviewing, narrative summaries of literature and then deciding what they thought was the best thing. And so kind of I'm from Mac, I'm like an EBM kind of person. Those sorts of things really give me antibodies. I find them very irritating. And so in response to this sort of expert opinion-based approach, I sort of started this body of work, and this all started back during actually my residency was when the protocol for this meta-analysis was published. And so I decided that I really wanted to unpack this because benzos are used everywhere. And so I really wanted to understand, are they actually harmful? Are they beneficial? And so we started this meta-analysis in, I think it was 2018, that looked at the safety and efficacy of perioperative benzodiazepine administration. And we looked at all the potential benefits and harms that we could think of. And so we did a really broad search strategy. We included more than 5 databases and a whole bunch of clinical trial registries. And we included trials reporting on adults undergoing inpatient cardiac and non-cardiac surgery who received any perioperative benzodiazepine from using any route, where in the trial that benzodiazepine was being compared with either placebo, nothing, or an alternative medication. And we looked at a series of outcomes that I'm going to go through here. So the outcomes that we focus on in the first paper that we published were delirium, intraoperative awareness, length of stay in hospital and ICU, and in-hospital mortality. We also looked at postoperative nausea and vomiting, postoperative cognitive decline, and overall quality of recovery, which is a bit vaguely defined, but I'll talk about that in a second. So we, the really broad question. And so as a result, really broad and admittedly very painful search. We identified and screened more than 30,000 titles and abstracts, and then went on to review more than 1,000 full texts to determine whether they were eligible, and included 320 trials in our systematic review. And so this was the first publication that came out of all this work. This was a systematic review and meta-analysis. We included in this initial stage of the work, we included observational studies. That turned out to be a mistake and created a lot of extra work, so we didn't carry on doing that. I'm just going to report on the RCT data here. So just before I jump into this, recognizing that everybody's from all kinds of different levels and backgrounds, I'm going to provide a little bit of an orientation to a forest plot because I have to apologize, there's going to be quite a few. So just for all of you who may or may not need to sort of blow the cobwebs off of your memories of medical school or national licensing exams or whatever. So if you have a forest plot, just to provide a bit of a quick guide, every line within this plot represents a study, and the little square in the middle of the line represents the point estimate with respect to the outcome for that study. And the whiskers on either side of the box represent the 95% confidence interval. The dashed vertical line in the middle is the line of no effect. So say, for example, if it was an odds ratio, it would be an odds ratio of 1. If it was a mean difference that you were looking at, it would be a mean difference of 0. And then the diamond at the bottom is the pooled estimate when you meta-analyze all this data, as well as its 95% confidence interval. And so just to, again, orient you to sort of what the meaning of all this is, if a confidence interval crosses the no effect line in the middle, either that study or the meta-analyzed result is not statistically significant. So firstly, this is benzodiazepines and delirium. So surprisingly, despite the guideline recommendations that benzos should be avoided because of their association with postoperative delirium, we actually found granted there weren't many studies, and there were only 1,300 patients included, but we found very low quality of evidence that benzodiazepines do not increase postoperative delirium, although the 95% confidence interval was fairly wide and just barely overpassed the line of no effect. So a lower end of the 95% confidence interval of 0.9. And so as a result, we call this very low quality of evidence of no harm. In terms of intraoperative awareness, so those of you who aren't anesthetists may be less familiar with this concept, but awareness is something that's really worrisome for patients. It's usually the things that patients are most afraid of with surgery. And in heart surgery, patients are at greater risk of awareness because of cardiopulmonary bypass, where you don't really have a systolic and diastolic blood pressure or heart rate, which are often indicators that would tell an anesthetist that the patient's a little bit light or they may be waking up. And so it tends to be more common in cardiac surgery. So the bottom line was that, again, as you can see, the overall event rate was very low. There weren't a lot of patients included, and the 95% confidence interval just barely crossed over the line of benefit. So we found that this was a very low quality evidence of benefit, but slightly significant. There are some limitations of this evidence that are important to acknowledge, though. So awareness is a rare event. So 5 of these RCTs actually reported 0 events. And that's why we did this. We undertook a different type of analysis that actually looked at non-events. So the likelihood if you received a benzo that you would not have intraoperative awareness. The low event rate, though, really limits the interpretability because the result is very fragile. So that even just a few patients switch from having an event to not having an event, the result would lose statistical significance. And then finally, the lack of depth of anesthesia monitoring really limits your ability to make causal inference about these sorts of things, just because they're not comparing, it's like comparing apples and oranges. So if you think of it, if somebody's getting an anesthetic and they get, I'm going to talk about the most basic anesthetic, is to be fentanyl, propofol, rock, and a benzo. And then in the other arm, you compare that arm to exactly the same anesthetic, but no benzo. It's hard to say that they're equivalent because you can't say that the depth of anesthesia is similar. If you give people more sedation, probably they're going to be less likely to be awake, regardless of whether it's a benzo. So that's probably the biggest limiting factor with respect to the existing awareness data. In terms of benzodiazepines and length of stay and mortality, not surprisingly, benzodiazepines didn't seem to have any effect on either hospital or ICU length of stay. And the effect of benzos on in-hospital mortality was unclear just because it was only reported by 1 RCT. So then we started to try and look at, so what it's like, benzo use is very common in the perioperative world. Anywhere between 60 and 90% of patients, depending on the population that you look at, are going to receive a benzodiazepine at some point during their surgical trajectory. And so we started by looking at postoperative nausea and vomiting, just because many people don't even think of this as a benefit of benzos. Surprisingly, in the oncology world, benzos are recommended for prevention of chemotherapy-related post-op nausea and vomiting, because they're thought to, nausea and vomiting in that context is thought to be related to anxiety on some level, and probably is pretty similar in the perioperative world. So in terms of, surprisingly, there are a lot of trials looking at post-op nausea and vomiting and benzos. And so most of these trials, admittedly, they didn't look at post-op nausea and vomiting as a primary outcome. It's just that when you look at anesthesia and perioperative research, post-op nausea and vomiting is commonly reported as either a secondary outcome or even just ancillary data. And so we identified quite a large number of trials and found fairly moderate certainty of benefit, regardless of how you define postoperative nausea and vomiting. So a number needed to treat of 16, which is pretty impressive, for postoperative nausea and vomiting. A number needed to treat of 21 for postoperative nausea. And then a slightly higher number needed to treat 55, which is still pretty respectable when you think of numbers needed to treat of most of the things that we use in medicine. So seems to work fairly well for postoperative nausea and vomiting, regardless of how you define it. So then finally, we went on to look at patient-reported outcomes, which are probably the most important outcomes to study. So when you think of patient-reported outcomes after surgery, these are the outcomes that are thought to best reflect the patient's overall experience. All of us tend to focus on morbidity, mortality statistics and outcomes, but most of the time, if you ask patients, they want to know how they're going to feel, Are they going to have pain? And so these are outcomes that are often ill-defined. We kind of broke them down into these 4 categories based on the trials that we identified. So we looked at postoperative anxiety, postoperative pain, patient satisfaction, and overall quality of recovery as measured using a validated scale. And so, so here we have the outcome of anxiety. We identified 22 RCTs and just over 2,000 patients. And surprisingly, so you'll notice at the bottom of the forest plot, there's that pooled meta-analyze effect that actually falls to the right of the line of no effect, and was fairly statistically significant, favoring no benzodiazepine. So we actually found, reviewing all of the literature, that receiving preoperative benzodiazepines or intraoperative benzodiazepines compared to either placebo, nothing, or another agent, patients were actually more likely to have anxiety after surgery than if they hadn't, surprisingly, which was unexpected. And we had updated the search several times, and no matter, every time we added trials, the point estimate actually just became more precise. In terms of postoperative pain, benzos aren't a common agent that's thought to have any effect on postoperative pain, but we thought we would include it just to be comprehensive. And, not surprisingly, we actually found moderate certainty evidence that perioperative benzodiazepines make little or no difference for postoperative pain, which is not unexpected. And again, quite a large number of studies, at least in the short term. Notably, most of these studies don't follow patients beyond 48 hours, just because they're looking at short-term perioperative outcomes. And then finally, benzodiazepines and patient satisfaction. So here, again, at the bottom, you can see the pooled effect. It's slightly to the left, but overlaps the line of no effect. So we found that benzodiazepines may actually decrease patient satisfaction, but the evidence was unclear and not statistically significant. And then finally, quality of recovery, you can see those point estimates at the bottom of the forest plot squarely in the middle of having no effect whatsoever. So no effect at all on quality of recovery. And then finally, so that, when you ask patients, most patients will talk about their overall experience and then their cognition as important outcomes to them. And so we looked at postoperative cognitive decline. We looked at this defined as global postoperative cognitive decline. So changes in a mini mental status exam or a MoCA equivalent. We looked at the domains of executive function as reported by scales like the DSST. And then we looked at memory. So in terms of, firstly, very poorly studied. Most of the studies are old. And the numbers are small, so it's hard to interpret, but we did find low certainty evidence that benzodiazepines increase postoperative global postoperative cognitive decline with a mean change in MoCA or MMSE equivalent that was about 2 points lower, keeping in mind that the minimally important clinical difference for an MMSE or a MoCA is thought to be about 2 points, but this is only measured up to about 48 hours after surgery. So somebody gets a benzodiazepine, it's hard to know if that's going to be a persistent effect or if that's just a short-term phenomenon. In terms of the other indicators of postoperative cognition, benzos had no effect on memory or executive function, but again, important to emphasize that no studies followed patients beyond 48 hours, which is a real limitation of this body of literature. So then just to pull it together before we sort of talk about the trial that we did. So in terms of the benefits of benzos, they may prevent intraoperative awareness with about a 7% decrease in the likelihood of having intraoperative awareness. They probably, I'm reasonably confident they decrease postoperative nausea and vomiting about 25% in usual care, but have no effect on pain, satisfaction, or quality of recovery. And in terms of the harms, they may actually increase postoperative anxiety. They may increase postoperative cognitive decline in the short term, but they have an uncertain effect on postoperative delirium. And you'll remember that initial meta-analysis where it seemed as though the trend was towards harm, but it was not statistically significant. And there are very important limitations in the evidence, both supporting and against benzodiazepines. So this gave, this all ultimately came, and informed the design and conduct of the trial that we just finished a couple of years ago. So the trial itself was called Be Free, benzodiazepine-free cardiac anesthesia for reduction of postoperative delirium. And this was a cluster randomized crossover trial. So again, I'm going to expand a little bit on delirium because I've kind of glossed over it. So just so people understand why this is really an important thing to study. Delirium is an acute disorder of cognition that affects at the very least 15% of patients after cardiac surgery. Anecdotally, working in the CVICU, I think it's a lot more common than that. But it really depends on where you're looking. And it's a very serious problem for patients and for healthcare systems. So anybody who's worked in this setting or anybody who works in medicine, frankly, knows how problematic and how challenging it can be to care for these patients. They stay in hospital a lot longer. They're associated with dramatically increased costs. And surprisingly, although most people think of delirium as an entirely neuropsychological phenomenon, these patients have a 32% increase in their odds of in-hospital mortality. Furthermore, the experience itself is very traumatizing for patients and their families, and such that, cohort studies that have followed patients with delirium in the longer term have found that about a third of patients who have delirium go on to develop post-traumatic stress disorder as a result. And we work with a couple of patient partners who have really attested to this and are very passionate about how upsetting it was for them. So as I've said already, benzodiazepines before and after cardiac surgery have been associated with delirium, and guidelines, both the perioperative guidelines that I mentioned, but also American Geriatric Society guidelines and Society for Critical Care Medicine guidelines recommend that they be avoided in older patients. But benzodiazepine use during cardiac surgery is very common, in contrast to this sort of more restrictive use before and after surgery. And this is primarily because they're thought to prevent intraoperative awareness as well as their hemodynamic properties, such that an observational study looking at patients having cardiac surgery in the US found that about 90% of patients get some dose of benzodiazepine intraoperatively. And up until this trial, no trial had examined the effect of restricting intraoperative benzodiazepines on postoperative delirium. So that really gave rise to our trial and the research question, which was, does an institutional policy of benzodiazepine-free cardiac anesthesia reduce the incidence of delirium up to 72 hours after cardiac surgery? And this was really a pragmatic question about routine clinical care. And so why did we study this at the level of an institution? And why did we study this as a hospital policy as opposed to just randomizing individual patients? As all of you working here know, cardiac surgical care is provided in very specialized institutions like the Heart Institute using standardized care pathways. And that's because the population of patients having cardiac surgery and the procedures themselves and the complications associated with those procedures are relatively homogeneous. And so in that setting where you have a relatively homogeneous population of patients having relatively similar surgeries, care is a lot more efficient and it's safer when it's provided according to standardized institutional care pathways. So I'm sure you guys have 1,000 of these care pathways and order sets and things that you don't even have to think about to make sure things are done safely. We certainly do in Hamilton. But in contrast, that's very standardized and protocolized care. Anesthesiologists generally choose whether or not to give benzodiazepines based on personal preference and what they think is the right thing. And so we felt that the best way to test the impact of restricting intraoperative benzodiazepines was through random alterations in standard policy at the level of an institution, because that's the way that care is normally provided. And it was really a very pragmatic question about routine practice. So what should the default thing be in everyday care? So this is just a picture that kind of shows what we did within the trial. The top part of the slide just shows current practice. So if you think of the red people as people who give benzos and the blue people as people who never give benzos, you can see that somebody having cardiac surgery, whether or not they get benzos, for the most part depends on whether their anesthetist is a red person or a blue person. And so we didn't actually really change current practice. All we did is standardize it, as you see in the bottom part of the slide. And so within every hospital participating in the trial, we standardized care such that hospitals were randomized to each crossover period, and they alternated between intervention and control at random. And so by doing that, we were able to evaluate the effect of these changes in standard institutional operating procedures on institutional delirium outcomes. So in terms of the intervention arms, the restricted benzodiazepine policy involved no routine administration of intraoperative benzodiazepines. Again, allowing for clinician approved discretion. So if somebody was having a seizure, you could give them benzos and so on and so forth. If somebody was benzodiazepine dependent, you could give them benzos. This was being compared with the liberal benzodiazepine policy, which mandated at least 30 mics per kilo of midazolam equivalent, which is a very low dose. And that was intentional because in some hospitals, they don't use very high doses. And so that was the minimum. Many places gave much higher doses. But again, allowing for clinicians to, for this policy to be filtered through the discretion of the clinician involved, so that if a patient had previously had benzos and developed delirium, they didn't necessarily have to give benzos. So like with any institutional policy, if you think of everybody gets Ansef on call to the OR, but the patient's allergic to Ansef, you probably wouldn't give Ansef, and that's the idea. And so in terms of the randomization schedule, we randomized the participating hospitals to apply policies over the course of between 12 and 18 4-week crossover periods. And we randomized hospitals to all periods in 2-period blocks. Overall, 9 sites completed 18 periods. Each period was 4 weeks again. 2 sites completed 17 periods and 9 sites completed 12 periods. I'm so sorry. I always have to apologize every time I pull up the slides. It's like seizure inducing. Close your eyes if you're prone. This is pretty much what we did over the course of the trial. It's not an exact replica, but this is conceptually what we did over the course of the trial. So you can see that some sites may have been randomized to go back and forth, but it wasn't every single period that people were alternating. We wanted to make it completely random to minimize bias and potential bias even more. And so we randomized all periods. Our primary outcome was the incidence of delirium up to 72 hours after cardiac surgery, as assessed by nurses in the CVICU and on the ward in routine clinical care. We collected intraoperative awareness as a safety outcome. Now, important to mention that patients weren't formally assessed by research staff for intraoperative awareness. This was collected from the chart. So if it was reported and documented in the medical record, then we captured it. And then post hoc, we also looked at the number of positive delirium assessments. So when you do a CAM, it can either be positive, delirium is present, or negative. And so we looked at count data for the number of positive delirium assessments. And then we also looked at lengths of stay and in-hospital mortality as surrogates of delirium. So we included 20 hospitals in Canada and the US, and just shy of 20,000 patients. 9,827 patients underwent surgery during restricted policy periods. 9,941 underwent surgery during liberal policy periods. And overall, really attesting to the dedication and the commitment of all of the NSs and all of the participating centers. Remarkably, despite, in a lot of these pragmatic trials, you'll see adherence is poor, 92% of patients were managed according to the policy, which was a huge accomplishment that we were really proud of. And overall, this was more or less the same across both allocations. In terms of perioperative benzodiazepines, so again, keeping in mind, this is a super pragmatic trial, and we were randomizing hospitals, so it was very challenging for us to control what's happening to patients before they got to us. So preoperatively, about 16% of patients got benzos within 24 hours of surgery. But when you looked at the intraoperative period, only 9% got benzos during the restricted periods, 93 got benzos during the liberal periods. And when patients did get benzodiazepines overall, so regardless of whether it was a restricted or a liberal period, on average, patients got about 4 milligrams of midazolam. So really not a very big dose. Postoperatively, about 11% of patients got benzos. So this was our primary analysis population. So you can see the overall, the adjusted odds ratio is 0.92. The 95% confidence interval crossed the line of no effect. So upper end of the 95% confidence interval of 1.01 and p-value of 0.07. So like, I don't know if any of you know David Mazer from the St. Michael's Hospital. He said, this is like my worst nightmare as a trialist, and it was sort of sucky. So in terms of intraoperative awareness, so despite the fact that everybody's so afraid of this intraoperative awareness, at least as reported in clinical care, so it came to the attention of clinicians, we had 0 cases. Wasn't really a thing. In terms of the number of positive delirium assessments postoperatively, we actually found that a restricted policy of benzo use decreased the number of positive delirium assessments with an adjusted risk ratio of 0.87, upper end of the 90 at 5% confidence interval of 0.98, and a p-value of 0.02. This is just a histogram that shows that adjusted count data. And so the red bars are the liberal periods, the blue bars are the restricted periods. And you can see that consistently over time from admission to ICU, there's a little bit less delirium when patients don't get intraoperative benzos. In terms of our secondary outcomes, restricting benzos had no effect on lengths of stay or in hospital mortality. So obviously, I mean, this is a super pragmatic trial. Adherence was excellent, but we still really wanted to unpack these results and remove some of the noise that was introduced through our pragmatism. And so we started by looking at excluding the patients within the restricted arm who had received benzodiazepines within the 24 hours before surgery. So patients who were getting Ativan for sleep the night before, or midazolam in the cath lab for their cath the day before, or whatever. And so we found that in this population, restricting benzos decreased delirium with an adjusted odds ratio of 0.88, upper end of the 95% confidence interval of 0.97, and p-value of 0.01. When we looked solely at the patients who were managed according to the intraoperative policy, this is in 92% of patients who were managed according to the period in which they went surgery. Again, we found that restricting benzos decreased postoperative delirium with an adjusted odds ratio of 0.9, an upper end of the 95% confidence interval of 0.99, and a p-value of 0.02. And then when we further removed from this analysis patients who had gotten preoperative benzos, the results became even that much more positive with an adjusted odds ratio of 0.87 and a p-value of 0.005. This is just a subgroup analysis. So everybody's like, wow, what about the patients who are on home benzos? What about the people who are alcohol drinkers? What about, this is probably just an effect of the elderly. It's only the elderly patients who this is really impacting. And so when we looked at all these subgroups, you can see that across age, the direction of effect is essentially the same, whether or not you look at younger patients or older patients, with the only difference being that in the oldest old patients, it actually appeared as though giving benzodiazepines had no effect whatsoever one way or another, which actually kind of makes sense when you think of it, because if your pretest probability of having delirium is 100%, then whether or not you get benzos or not probably isn't going to make a difference. But again, same direction of effect, even if patients were heavy alcohol drinkers at baseline. Many think of benzos as important to give in that population because they tend to be GABA upregulated because of chronic alcohol use. There was no difference. And again, if patients were on home benzodiazepines, again, similar direction and magnitude of effect across. So in conclusion, we included in our paper anyways, that by intention to treat, restricting our restricted benzodiazepine policy did not reduce postoperative delirium, but because there was no evidence of adverse events, and our on-policy analysis showed about a 10% reduction in delirium with benzodiazepine restriction. With a larger effect size, the more that benzodiazepine exposure was eliminated, we felt that it was important to at least say that restricting, or at least the journals made us say that restricting benzodiazepines could be considered. And so that was our conclusion. So just to sort of pull all of that data, I've like rambled on and on about all these meta-analyses and stuff. So again, just to reiterate, in terms of the benefits of benzodiazepines, they decrease post-op nausea and vomiting, but have no effect on pain, satisfaction, quality of recovery, or intraoperative awareness. In terms of their harms, they may increase postoperative anxiety, they may increase cognitive decline, at least in the short term, and they probably result in at least a small increase in postoperative delirium. And so, recognizing that perioperative benzodiazepines don't improve the patient experience of surgery and probably result in some small increases in adverse outcomes and unpleasant experiences. Generally, I mean, at least within my practice, I've started to turn to alternatives. So whether it's for sedation, I think a lot of people don't really think of antipsychotics as that things that can be used as sedative agents, but we use them in the ICU as sedation all the time. And so they're like quite reasonable to give. They're available in both oral and IV form. Opioids are pretty reasonable. And interestingly, despite the fact that people think of opioids as deliriogenic, in general, that like in another analysis that didn't bear out in our data, propofol is a reasonable sedation agent. And in terms of an induction agent, if you're an anesthetist for anesthesia, a nice hemodynamically stable agent in patients who are not septic is etomidate. And so at the end of the day, though, you have to look at the patient in front of you and sort of consider that individual patient's risks of harms versus their probability of benefit in the overall scheme of things. So with that, I will end the presentation. Thank you for your attention.
Thank you very much for that presentation. That was very educational for myself, and I think also for colleagues in cardiology and cardiac surgery as well. So thank you very much. First, we'll take questions from the audience. This is a portable mic, so if you're in the middle sitting, Allison over there has a mic that you can talk into. So just put up your hand. Perfect.
Congratulations, really enjoyed your talk. It's a huge undertaking, 20,000 patients and with this randomization scheme. The obvious question was, could you see a dose effect relationship with the benzos?
Yeah, a very good question. We did see a dose response relationship which didn't suggest that there was a dose that was safe. It just suggested that the risk increased the higher the dose was.
I have a practical question for you. For those patients coming through our PAU or that we're seeing like urgently coming to the OR for cardiac surgery, you said antipsychotics, but what do you actually practically do, especially in a PAU setting where the patient says, like, I don't even think I can get to the OR. I'm so stressed about my surgery in 3 days. What are you and your colleagues, if your practice has changed at McMaster, what are you prescribing for those patients preoperatively or intraoperatively if they're coming for more urgent surgery?
To be honest, a lot of the time, I mean, but it's pretty unusual that we'll prescribe anything. If anything, usually, like a non-deliriogenic sleep agent, we'll recommend melatonin. Sometimes if people are really, really worked up, Seroquel, a low dose Seroquel. Or there's also several other sleep agents that are being used more commonly in settings. So trazodone is a SSRI family based agent for sleep, or lemborexant. Those are becoming very popular these days. They're like REM sleep promoters. So all of those are things that you could consider, but it's pretty uncommon that we actually send patients home with anything. Most of the time, we try to just talk to them. And same thing in the pre-op area. Most of the time, actually just talking to patients and validating their concerns and addressing their concerns is more than enough. But if people are really, really anxious or upset, then any of the things listed, low dose opioid, whatever is appropriate to the setting and the degree of monitoring.
I'll suggest a question for interventional cardiology fellows. I'm wondering if you've noticed a change in your practice with the STEMI codes coming in and the sedation that's provided, considering you're the primary site for these studies. Have you noticed a change in practice? And if yes, what has the change in practice been?
Small, yes. There's a big disconnect between the OR and the cath lab. And I think a lot of people just sort of go with their default thing, which is easy. But there are more, like, people are using lower doses of sedation, and they're using even things like gravel to help people calm down. Most of the time, again, unless somebody is very anxious or worked up, most of the time patients can tolerate a cath reasonably well without a lot of sedation.
There's 2 questions from online. So one question is from Dr. Chen. Why in the setting of propofol anesthesia should an additional GABAergic medication make a difference?
It's a good question. I think it just speaks to the fact that we don't really understand how most anesthetics work. It's a reality, and we don't really understand what causes delirium either. So the short answer is I don't know. It's a good question.
second one before Dr. Beeman takes over. Did you account for alpha-2 agonist administration as a confounder in your results?
We didn't account for it as a confounder, but we reported it in the paper itself. So a small number of patients were getting Precedex intraoperatively and postoperatively. It was completely balanced between arms. And so we didn't look to see if it diminished the effect size. But my personal opinion is, at least when it comes to Precedex, there's a lot of hype about how it's like the next best thing to prevent and treat delirium. Anecdotally, in the ICU setting, I find it doesn't really do anything about delirium. It just transforms hyperactive delirium, which is challenging and hard to manage in that setting, to hypoactive delirium. It just sedates people.
Thanks so much for coming, Dr. Spence. Really enjoyed your presentation, and congratulations on all your success and the impact of the work that you're doing. My question's on the trial design format. So I'm curious to know, you use this cluster crossover design. When we see that grid as like, it looks kind of, it sort of freaks me out a little bit. And I wonder about if you could talk about the advantages and disadvantages of that type of design, running it for the 20 hospitals as opposed to a standard RCT.
So it'd be interesting. Deb Siegel is here. Deb and I are leading a trial right now that you guys are going to take part in, looking at cluster trial, looking at autologous priming the bypass circuit. So there are a bunch of advantages and disadvantages. It's not for every question. You should not think that this is the panacea to just doing big studies quickly. That is wrong. The time when it's appropriate to choose a cluster randomized design is when you can't actually possibly answer the question using any other type of design, and when it's the most appropriate choice to answer that question. So if your question is about a pragmatic intervention applied at the level of an institution, then and you can't possibly deliver that intervention across the intervention without including all patients, then it's probably an appropriate design. But if you want to do an explanatory trial that is looking at the efficacy of an intervention, almost certainly the wrong way to go. And that's for several reasons. Whenever you randomize hospitals as opposed to individual patients, without getting too much into the stats, there's a huge loss in statistical power that comes as a result of the clustering of patients and the similarity in outcomes in patients within an institution. And so as a result, you normally need much larger sample sizes using a cluster randomized design to answer the same type of question. We made a couple of choices intentionally to try to overcome some of that loss of power. So every single time that a cluster is randomized to an intervention and they alternate to the control arm, they're acting as their own control. And so in a way, by having a hospital alternate between intervention and control, every time they cross from intervention to control, you regain some of the statistical power that's lost as a result of clustering, which was the reason why we did this like bananas number of crossovers, is because every single time it's like you're re-randomizing the hospital. And so you regain statistical power every time. So, I mean, the ideal thing would be to have a crossover period that lasts a day. But to some extent, you have to balance, feasibility with ideals.
Any challenges with the electronic health record with cluster design?
No, if anything, an electronic health record is an advantage, right? Because then you can just data dump a lot of the information that you're looking for if you just code the patients that are included. At the time that we started the trial, I mean, we started just before the pandemic. It was like the worst timing. I think we started in like November 2019. So a lot of the hospitals weren't actually using EMRs, but since then now, as we're going forward to designing this new trial, we found a lot of efficiencies that come either by doing sort of data extraction using the chart, or just having something where the data is more organized. So research staff aren't sifting through like handwritten notes and stuff and trying to interpret anesthetic records with like seagulls and hatches and stuff.
Thanks so much. A wonderful trial and a huge undertaking. I'm one of the anesthesiologists here. Just wonder if you could speak to, patients at the extreme of our practice. I can think of a few patients, burnt out AS, EF of 15%, bolt upright. I'm, worried about them dying on induction of anesthesia. benzos in that situation, I'm not so much worried about delirium and the smaller effects, but just the effects of inducing them. I wonder if you could just speak to that. And then was there a number needed to harm calculated in the post hoc analysis?
So great question. So at the end of the day, I mean, I'm sort of reluctant, especially in these extremes, to actually recommend, because our trial wasn't really designed to look at extremes. It's designed to inform your everyday clinical decision making. So what I would say is that in these extremes where you're worried about keeping the patient alive, you probably should default to whatever it is that you're most comfortable with and what you think in your hands will keep that patient safe. I mean, to be perfectly honest, I've started using a lot more etomidate since then. I love etomidate. It's way more stable than benzos. It's awesome. One of my favorite anesthetic agents. And I know there's a lot of concerns about sort of adrenal suppression, but at least the evidence that I've reviewed is pretty limited and weak. And so I still use etomidate a fair bit. But ultimately you have to use what in your hands is going to be the safest for that patient at that point in time, I think would be the short answer. In terms of the number needed to harm, we did calculate it off the top of my head. It wasn't, I mean, it was large because the event rate was relatively low and the effect size was small. So probably it was about 80 patients, but not dissimilar from most of the interventions that we use. I think the number needed to treat for DVT prophylaxis to prevent a PE is like, what? Yeah, 300. Deb knows these numbers.
Well, thank you very much. That was a really wonderful talk, and thank you for the question and answer session.
Thanks so much.